Thank you again, everybody, for being here today. This is the first West Yorkshire Ghana Mental Health Knowledge Exchange event. So my name is Tim. I'm the head of global partnerships at West Yorkshire Integrated Care Board. So just to orientate you to West Yorkshire in the first instance for colleagues in Ghana, West Yorkshire's in the heart of England, and our region comprises of five places. Some of the cities in those places you may have heard of, called Leeds and Bradford, Wakefield, for example. So we're a system that sort of cares for 2.4 million people. Um, and our integrated care system looks a little like this, like a variety of organizations who are kind of responsible for the health and care of our citizens. And many of our partners are here today from some of the mental health trusts. So I just wanted to kind of give a bit of an overview to where West Yorkshire is and what our integrated care system looks like. But part of our part of West Yorkshire is being a good global citizen, and we're committed to working in an ethical, sustainable, and inclusive way to develop health and care and tackle challenges in West Yorkshire and internationally as well. So, working alongside our NHS England colleagues, we're really proud to have established some unique partnerships, global partnerships with countries including Kerala within India, Uganda, Ghana, South Africa, St. Vincent and Grenadines, and Montserrat. So we're here today, obviously, to sort of launch our partnership with Ghana. And I thought it would be rude not to share a map of Ghana for our kind of UK attendees as well. So Ghana, of course, in West Africa, about 35 million people in Ghana, and I believe 16 regions. So I hope we've got many of the regions from Ghana here represented today. So maybe use the chat function throughout the event and let us know where you're sort of calling in from, which would be great. But yeah, the partnership with Ghana is a managed education partnership, again in association with NHS England. So the typical makeup of a partnership like this is involve virtual knowledge exchange. So we're here today, our first event, and over time we also hope to facilitate more observership type experiences. So visitors from Ghana spending time in the NHS and in West Yorkshire, and also fellowships, which is NHS people spending the time over in Ghana as well on study visits and longer term fellowships, which would involve doing quality improvement projects and contributing towards priorities in Ghana. So I was really pleased to be part of a visit to Ghana in March with other colleagues from NHS England and West Yorkshire, where we held a workshop around maximising potential of the mental health workforce for the benefit of patients in Ghana through education training and workforce transformation. So that's what this partnership is all about. And today we're here with a real nice mix of colleagues from the NHS and from Ghana to really make a start on that knowledge exchange aspect of the partnership. So today we've got a great agenda with some opening remarks from Professor Jed Byrne, Director of Global Health, NHS England, and Mr. Lawrence Lawson, Deputy Director and Head of Human Resources, Training and Development at Ministry of Health Ghana. And then we'll have some further presentations from colleagues in Ghana and colleagues in West Yorkshire who will introduce as we get to that. So without further ado, I'd love to introduce Professor Jed Byrne for a few opening remarks. Thank you, Jed.
Thanks very much, Tim. Very much appreciated. As you might be able to tell by my strange set of pajamas that I'm wearing at the moment, I'm currently in hospital where the Wi-Fi sometimes is not that great. So apologies if you struggle to hear everything I've got to say. I'm in a very fortunate position that very early on in my medical career, actually as a medical student, I found myself learning in India. And I was there on a medical elective for 3 months in the 1980s. And that experience changed my life. And actually, the reason why I'm here today, and I guess a lot of the reason why NHS England have been so enthusiastic about this agenda is due to those early experiences where myself and others recognised the power of clinicians, particularly learning in a global learning environment and then bringing that learning back into local healthcare for the purposes of healthcare transformation. Through that learning over the years, I've retained a really big interest in global health. And in fact, over the last 3 decades or so, it's become predominantly what I do for a living. And I'm now the Director of Global Health at NHS England, but I've also a very part-time surgical oncologist. I am a surgeon for cancer. Here in West Yorkshire, I mean, personally, I am from Liverpool and live in Manchester. However, somewhat ironically, my favourite place on the planet is West Yorkshire, which is across the Pennines and traditionally has quite a competitive relationship with the area of the country that I'm from within England. And the reason I love West Yorkshire so much is that they have led as a healthcare system the basic principles of global healthcare partnership in transforming local healthcare systems through mutual growth and mutual health system strengthening. It's effectively become the engine room of global health partnerships for us in the NHS. You will know that we are extremely fortunate in England. We have the oldest and largest universal health coverage system in history. We employ 1.4 million people and deliver healthcare free at the point of contact to all of our 60 million population, and have done since 1948. And so we have a lot of experience of universal health coverage development and delivery. But the reality is, like all things, they get old, and we know that we need to change and adapt. And one of the things that we've realized through our global relationships over the course of the last 20 years or so is that we cannot do this on our own, and that in order to transform, we need partnerships. And the unit which I lead for the NHS is focused very much on the promotion and development of those partnerships. And working with West Yorkshire, we have developed a whole series of partnerships at 4 specific levels. They are government to government partnerships, which we think are really important, getting a broad agreement of friendship, collegiality and collaboration between governments, which allows a framework for us to work within. Then system to system partnership. The NHS itself is divided into accountable care organisations, and those organisations are responsible for the health, wellbeing and social care of groups of population. And it's where our learning and transformation is occurring at the moment. And it gives us an opportunity to link with other systems for a transfer of knowledge, people and innovation. We then have institution to institution partnerships, and West Yorkshire is very lucky to have some of the best healthcare delivery institutions and supporting higher education institutions, not only in the country, but also in Europe and globally. And then finally, and perhaps most importantly, NHS England, together with West Yorkshire, have been encouraging the development of close working friendships on a peer-to-peer basis with colleagues across the globe. In terms of what that looks like specifically, I just want to mention 2 partnerships that West Yorkshire are now heavily involved in, which we've been very privileged to help with. The first of these is St Vincent and the Grenadines, and the second is in Montserrat. And these 2 islands in the Caribbean, both of which are very different, we have responded to mutual need and set up a sustainable relationship between institutions and systems within West Yorkshire on both a peer-to-peer basis through observerships, fellowships, the development of community of practice, institution to institution partnerships, for example, between Leeds Teaching Hospital, the largest trust in the West Yorkshire region, Yorkshire Ambulance Service and the St Vincent's and the Grenadines Ministry of Health. And we've also set up a peer-to-peer and institution to institution partnerships between Calderdale and Huddersfield NHS Trust and the Montserrat Ministry of Health. We are very keen on developing mutual healthcare leadership, allowing an exchange between 2 healthcare systems, again for mutual benefit. And we've done that on a system-to-system basis in West Yorkshire for some period of time. The managed educational partnership between St Vincent's and the Grenadines and West Yorkshire is a flagship programme for us in England, and began really with a single conversation with the High Commissioner of St Vincent's and the Grenadines back in 2017-18. During the period of that partnership with West Yorkshire, There have been 3 workforce planning workshops focused on mutual workforce transformation, which have led to the development of a significant number of people exchange programs. There have been 3 cohorts of St Vincent's and the Grenadines observers who spent 8 weeks in clinical placements within West Yorkshire across infection prevention control, stroke, mental health, renal and elderly care. We've had 5 cohorts who've had 6-month placements in St Vincent's and the Grenadines derived from the West Yorkshire Integrated Care System. And there's also now a collaboration between the Yorkshire Ambulance Service and St Vincent's to mutually bolster urgent response facilities in both health areas. More recently, Leeds Teaching Hospitals in West Yorkshire are in the process of co-designing a knowledge exchange placement model, which is a new strand of the partnership offering short, structured opportunities for NHS staff, promoting reciprocal learning and helping and embed improvements across both systems. Central to this whole process, of course, is diaspora staff, and we owe a significant debt to West Africa and to Ghana for healthcare professionals who have graduated in those countries or have been educated in those countries that have come either temporarily or permanently to work within the NHS. And we recognise that, but we also recognise the power of those individuals that are working within the NHS to create sustainable links with their country of origin. And we're very heavily dependent on our diaspora staff in order to achieve that. I am conscious of time, but just very briefly to mention the Montserrat link, which is looking at a collaboration in a different way. Again, with partners in West Yorkshire ICB, we've delivered in-country acute clinical skills training, observer placements and quality improvement fellowships. And we have a virtual offer as well to promote and enhance peer-to-peer relationships. This has been enormously important to the NHS itself in understanding the challenges that are faced by these different clinical environments across the world. And we'd like to think that we've also participated in strengthening those systems as well. And we look forward to be able to do the same thing with our Ghana relationships. None of this would have been possible without the extraordinary energy and leadership of the West Yorkshire team, including Jonathan, Tim and others who you were going to be speaking to or you're going to see and hear from this afternoon. And so I feel really excited and really privileged to be here today at the beginning of what I suspect will be a long-standing and extremely impressive, mutually beneficial health system strengthening partnership. So thank you very much and have a wonderful afternoon.
Thank you very much, Jed, for that great overview. And I guess this is early days of our partnership with Ghana, but that's gives some good examples about what experience we can lean upon and how to develop this partnership along the lines of other partnerships as well. So thanks again. So can I now invite Mr. Lawrence Lawson, Deputy Director and Head of Human Resources at the Ministry of Health for Ghana, for a few opening remarks.
Thank you so much. Right, good day to you all, distinguished ladies and gentlemen. On behalf of the Ministry of Health of Ghana, I welcome you to the first virtual knowledge exchange event on mental health services in Ghana and England. This initiative aims to facilitate the sharing of knowledge on national mental health systems to enhance understanding and partly drive our health sector development. As we are all aware, this event is part of the Managed Education Program partnership formed between the Ministry of Health of Ghana, the NHS in England, and partner organizations in West Yorkshire. To be honest, we respect and warmly acknowledge the strong involvement of Mental Health Authority and Ghana Health Services, in addition to all registered partners for the process engaged so far. In this same vein, as we move along, we are so delighted to have speakers from Leeds Trinity University and some agencies of the ministry, notably Mental Health Authority and Ghana Health Service, joining us today on this platform to share insights on mental health care approaches in both Ghana, and England. I know we'll have a lot to discuss and a lot to share. Over the next hour and a half, we will be exploring these approaches, discussing opportunities for collaboration and strengthening international partnership in mental health. Ladies and gentlemen, we look forward to very productive discussions in order to have insightful and productive activities as we move along. Allow me at this point to say thanks to you all, even as we engage in the process to make meaningful strides. Thank you.
Thank you, Mr. Lawson. Yeah, you've said it all. That's exactly why we're here today. So it's all about exchanging knowledge between our two systems, and it's the early start of our partnership. So we do hope that we can have further sessions like this in the future, and we'll come to that at the end in terms of what might be next for this series of events. But again, so I think now might be the time to hand over to our experts and introduce Dr. Caroline Emissa, Deputy Director General at the Ghana Health Service, alongside Dr. Jamwa Oper-Addo and Reverend Dr. Joseph Adu, Specialist Psychiatrist for Eastern and Greater Accra regions, respectively. So, Dr. Caroline, if you're connected, I'm ready to host your slides for you.
Thank you very much, Tim. Good afternoon to all of us. I'm happy to be here. This is the first Ghana UK virtual knowledge exchange program, and as Ghana Health Service, we are in collaboration with the Mental Health Authority to ensure that mental health services are available and accessible all across 16 regions of the country. So I'm really happy that this is happening and we are part of it. So generally, my presentation, I've been told I only have about 20 minutes. So I'll just give a brief overview of Ghana's health system, and then the health service delivery aspects to mental health, of course, the legal framework and policy within which mental health services are provided, and then what challenges we face. Some way forward, I think, would help us to mitigate some of these challenges. And then finally, I'll conclude. So this is a general overview of Ghana's health system. We have the Ministry of Health, that is the parent or the largest ministry, the ministry responsible for healthcare sector, for the healthcare sector. And then we have various agencies that operate under the ministry. In fact, we have close to about 30 agencies. Some are responsible for service delivery and public health services. We have our regulatory agencies. We have research and training agencies. Then we have some quasi-government and other agencies, all under the Ministry of Health. Talk about service delivery. It's largely provided by the Ghana Health Service, which is responsible for the primary and secondary care levels. And then we have our teaching hospitals at the national level responsible for tertiary services. But of course, we have other agencies that collaborate with the service, like the mission facilities. We have the CHAG, which is the Christian Health Association of Ghana. We have also the Ahmadiyya Muslim Mission that also provides some healthcare services in Ghana. Of course, talking about mental health, I want to mention that we collaborate with the Mental Health Authority to also provide some tertiary level services at the national level. So Ghana is fortunate. I know a lot of countries do not have this going for them, but we have been able to get a legal backing under which we provide mental health services, and this is enshrined in the Mental Health Act 846/2012, and our mental health regulations LI 2385. So the mental health has been established under this mandate, and the mandate allows it to collaborate and ensure the provision of quality mental health care through the integration of mental health services into our general healthcare system, protecting the rights of our patients as well. And in 2019, the authority was able to come up with a 12-year mental health policy that drives the integration of mental health care, obviously by prioritizing primary health care through such comprehensive strategies of prevention, health promotion, clinical management and rehabilitation. And this is across all the levels of care, which we will see as we go on. Next slide, Tim. So like I must have mentioned, Ghana Health Service is the largest health service provider with presence in all 16 regions and across 261 districts in the country. Of course, we are supported largely by our collaborators, Christian Health Association of Ghana and other mission hospitals like Ahmadiyya Health Services. We also have private facilities that provide mental health services, as well as our quasi-government and security services. We have the police hospital, we have 37, we have the bank hospital, of course, we have SNIT hospital, as well as our teaching hospitals and the three main psychiatric hospitals that also collaborate to provide health services in the country, including mental health services. So this is some sort of flow charts to give us an idea how the health delivery services are provided. I mentioned we have the national level, we have regional levels, because we have 16 regions of the country. We have districts level, then we have our sub-districts and then community level. So at the national level, MHA is responsible for policy formulation and of course ensuring that mental health services are provided across all service delivery agencies. At the regional level, we have our regional mental health committees. These are synonymous to the MHA, that's the authority at the national level, but they play a role at the regional level to ensure that the mandate of the authority is carried through across all agencies. And then at the district level, we have a similar structure. At the sub-district level, we have the sub-district health management teams, which also play that role of ensuring and coordinating mental health services. And at each level, we have the different types of facilities that serve the public or the population. So at the community level, we have our very basic unit, which is the CHIPS level, that's the community-based health planning and services. This is the structure for providing healthcare services within the community. So at this level, we have our community mental health officers or nurses. We also happen to have our clinical psychiatric officers, medical assistants who have been trained in psychiatry, who are being phased out. So now they are being replaced by the physician assistant psychiatrists. So these are physician assistants who have had some top-up training in psychiatry. We also have our social workers at the community level. And of course, we also work with traditional and faith-based healers and volunteers at the community level to all make sure that services go all the way to the community. Then at the sub-district level, we work with our health centers, which are usually manned by physician assistants or the CPUs, which I mentioned earlier, as well as some trained providers. So we have some general practitioners who have been trained in MHGAP to also be able to provide mental health services at that level. At the district level, we have our district hospitals, and it's led by the DHMT, that's the District Health Management Team. And they also provide services, mental health services at this level. As we go along, we'll see exactly what kind of services they provide. And also we talk about our regional hospitals at the regional level to provide healthcare services. And at this level, we also have our psychiatrists, we have some psychologists. Some CPOs are also found at this level and at the national level. You see, we have some rehab services at the national level, and this is largely done by the psychiatric hospitals. So these are the long-stay psychiatric hospitals that are supervised by MHA. Like I mentioned, we will talk about some level-specific packages at the various levels. So at the very lower levels, which are the which is the primary healthcare level, the CHIP zones, we have our mental health promotion. It's largely mental health promotion and prevention. We also, at this level, are able to identify some challenges, basic challenges in mental health, and provide some psychosocial first aid or support. Then we also have some community interventions, largely at this level, where we have school mental health, we visit homes. Our community mental health officers are responsible for home visits and then outreaches, as well as some health education through community there. But of course, I mentioned at this level, we collaborate a lot with other healthcare service providers, both formally and informally. So formally, we work with some traditional and faith-based organizations or healing centers that we find some of our clients in, as well as working with some CSOs and NGOs, largely at this level, provide some of the services or interventions I mentioned earlier. Then we move to the health centers and the district hospitals. So at this level, there's some form of clinical assessment and diagnosis that is done with treatment with psychotropic medicines. I think I mentioned that at this level, we have physician assistants, and then we also are able to have some GPs who have been trained in mental health to provide psychiatric services. So we have clinical assessment and diagnosis. We have treatment or management of persons with mental illness at this level. We also are able to use the MH gap, like I said, train non-psychiatric or non-formal psychiatric officers to be able to provide psychiatric services and know when to refer, etc. There's also some task sharing where we have trained some psychiatric nurses to provide care at the community level. Then we also have some pre-service training. So nurses, doctors, etc. would have rotations at this level and be able to have some training in psychiatry formally at this level, especially the district hospital levels. And I think the Ghana Health Service is trying to identify some of these hospitals to retool and also equip them with the adequate resource to do some more training at these levels. At the regional hospitals, that's where most of our secondary care takes place. So here we have some sort of stabilization for clients. It's usually short stay, look at about 2 to 4 weeks sort of admissions at this point. Then at this point, we also liaise with psychiatry services for admission in other wards. So there may be some psychiatric or psychologist support for medical wards, surgical wards. They all occur at this level. We also have some clinical supervision and training for our psychiatric services at this level, at the primary healthcare level. It happens at the regional level. Then, of course, there's coordinated back referrals to the community. So when patients are well or are stabilized, they are referred back because there's the idea of providing care as close to the people as where they are and where they live. So we have a system where some levels refer back to the lower levels of care where the patients will still be supervised to make sure that they recover properly. Next slide. Then I mentioned the teaching and psychiatric hospitals at the national level. So these are the services that manage complex or acute cases that may have been referred from the lower levels. That is where we also have most of our long stay admissions. So the three main psychiatric hospitals located in more of the southern region, southern part of the country, that is in Accra, and in Greater Accra and in the central regions, we have Accra Psychiatric Hospital, Pantan Hospital, and then Ankapo Hospital. So they are responsible for our long stay admissions. Obviously, we have some admissions in our teaching hospitals as well. Talk about Kolebu and Konfanoche teaching hospitals, and indeed the Tamale teaching hospitals. I must quickly add that some regional level hospitals have transitioned into teaching hospitals. So now we have some services being provided in Sunyani Teaching Hospital, which used to be one of our regional level hospitals not too long ago. Of course, and in the Volta region as well. Then, of course, there's also liaison psychiatry services at this level. So we collaborate with other wards outside psychiatry to provide psychiatric services also at this level. And from this level, we still will have some referrals back to the primary health care level or the community level for community services. I mentioned the basic services of supervision and being able to rehabilitate people or to supervise persons with mental illness at this level to ensure proper recovery or complete recovery. Talking about detention and admission. So there are some detention services available at the CHIPS level. Usually at the CHIPS or health center levels, we have some detention over 24 hours, basically less than 24 hours or up to 24 hours. And then from 48 to 72 hours at the district hospital level to stabilize clients and to be able to monitor them. Indeed, if they need some referral, they are able to be referred from this level to our secondary care levels or our national levels, which of course are the long stay places of care. So I must quickly add that at the district levels, there are no designated wards or mental health wards. Rather, we have some virtual beds that are able to admit persons with mental illness if they are found at this level and they need admission. So it is kind of fluid, but of course, there's that framework to make sure that people with mental illness who may need some admission for about up to 2 weeks are able to be admitted on some of these wards. Then we also have the short stay admissions for about a month, which is up to 4 weeks in our regional hospitals. Unfortunately, we've lost two of them to the teaching hospitals, and so they have become whole, and Sunyani regional hospitals have now become teaching hospitals. So we have lost the designated mental health wings that these regional levels used to have. So we need to look at the policy for making sure that all regional hospitals have some form of psychiatric wings. But I must quickly also add that there's been some regional psychiatric hospitals being put up. There are some psychiatric hospitals being put up at the regional levels to take about 50 beds solely for maybe medium to long-term psychiatric health services. Yes, at the regional levels. These are in the northern region and then in the Ashanti region. Talking about rehabilitation and community integration. So we have some functional rehabilitations, skills and daily living support, return to work or school plans, linkages to social welfare and livelihoods, and other step-down arrangements happening across all levels of care, I must say. So the community levels, we have CSOs and NGOs like Basic Needs Ghana, who provide livelihood and skills support to clients. This is embedded with clinical follow-ups and then community daycare, day centers. We also have some support. This is largely in Tamale, and Accra. So in the Basic Needs works usually in the northern region and some areas in the Greater Accra region. We also have the CHAC facility, House of St. Francis, in the Greater Accra region, also providing some therapeutic community models where we have people going for detox, we have counseling sessions, then we have family therapies, and they also support with client reintegration back into the communities. I must mention that there are so many of these organizations. I will not be able to mention all, but we have other foundations providing sort of halfway homes for persons who need recovery or support from addiction, and also to be able to provide proper community re-entry. So we have some support in these areas, though they are really or largely restricted. So that doesn't really cut across like our mental health services in terms of promotion, prevention, and then treatment. Obviously, we have our tertiary and psychiatric hospitals providing some occupational therapy services. So these are largely government or public institutions, and we are hoping that with time or as the regional hospitals regional psychiatric hospitals concepts come up, they will have these units or departments embedded to ensure that people get their full recovery. Next slide. So what are some of the challenges within the health sector, especially when it comes to mental health services? So though there are clear referral systems or pathways from the various levels of care, so from trips to the health center, from the health center to the district hospital, from the district hospital to the regional hospital, and then to the national referral centers. It's kind of weak. So patients sort of become a bit frustrated when they are referred to get to these places. So I think we'll have to look at ways of trying to strengthen these referral systems as we go along. And then there's still a lot of stigma among not just patients or within communities, but among health staff. There's self-stigmatization, there's peer stigmatization, and all that is still rife, and it needs to be talked about. There's also inadequate supervision and monitoring. So different levels are not well equipped to be able to provide monitoring and support supervision to maybe at lower levels of care. So the region should be able to monitor district hospitals. It is done within the general healthcare system, but sometimes we find that because of inadequate resources or capacity, mental health services does not get this done very well, because there are competing priorities in our already overstretched primary healthcare settings, such that there's minimal funding allocated to our community mental health activities. And I think this reflects in the inadequate supervision and monitoring that we just talked about. And of course, we also have issues with data. This is a countrywide problem, or should I say it's a nationwide problem. We still have to really work hard on our data. And Mental Health Authority has been doing a lot of work in this regard. I know they are working with the Ghana Health Service team to be able to input appropriate data, relevant data, accurate data into the national database, which is the DIMS2. Currently, I must say that there are issues with this DIMS2 hosting, and we need to really work hard at it. I know the ministry is working to bring into existence the Ghana Health Information Management System, which will be in country, manned here, controlled here, with all the data against being done here, so that we are able to have real-time accurate data. And so talking about mental health data, if the whole data structure is well done, hopefully mental health should be taken care of, and then we should be able to have relevant data, accurate or appropriate data. And this comes with capacity building. So some training has to be done in this area. I think these are just some ideas shared on how to improve on some of the systems or the challenges I talked about. So I mentioned the referral systems. We need to strengthen that. We also need to heighten our rehab and reintegration processes. I don't think there's any formalized system for rehabilitation and reintegration, especially with reintegration. I know that various levels can send clients across the various pathways, but as to whether patients are comfortable and know what to do, I think we need to look at increasing the information, not just within the health delivery space, but rather on the other side as well, where the patients are concerned. And then also we need to combat the stigma. I mentioned that a lot of stigma, and to be able to empower our communities to reduce stigma. So we can increase our anti-stigma campaigns in schools, across media networks, within our communities through their best. And I must say that the peer or self-help networks that are being organized by our CSOs and NGOs need to be strengthened. So they are doing these, but in very limited areas. Like I said, they are not able to have a very wide or nationwide angle to this when it comes to self-help groups or supports. These are largely being championed by CSOs and NGOs, and they are not able to reach everywhere like the government system does. Then I also mentioned about human resource. Maybe I mentioned that we've had to use volunteers and train other cadre of staff to be able to provide mental health services so we can scale up the mental health gap training, and then also strengthen our community health worker roles. So there are different groups of community health workers. There's a social, what do you call it? Welfare. I think that is also not too strong. They are under-resourced, I would say, and we need to look at resourcing them to be able to support with mental health services, especially at the lower levels of care. I've talked a lot about data, and we need to improve our routine supervision and monitoring and ensure that we have accurate data so that we can make evidence-based decisions when it comes to mental health. Next slide, team. So just to conclude, I hope I'm within time. I think that Ghana has been able to establish a robust policy and legal framework for a decentralized community-based mental health system. And some of our key pillars are the decentralized care. I've mentioned that now the paradigm has shifted from institutional care to more community care services, and these are delivered at all the levels of care, all the way down to the CHIPS level. And this, of course, has made it easier to bring care to the communities. But I think we still have a lot of work to do. We also have a lot of multi-stakeholder collaboration. So there's been some strong partnerships with the Ghana Health Service, CHARG, CSOs, and other development partners to enhance reach and impacts for the Mental Health Authority. We also have community-focused models such that these initiatives in peer support, caregiver education, and rehabilitation have gone a long way to foster recovery and also to ensure social inclusion. So I think this is my last slide. Yes, thank you very much. And thank you. Yeah, thank you.
Thank you very much indeed. That was a very, very helpful overview to the Ghana health system and mental health system. Obviously, this is the first of our events, so we felt it's important to give that overview to our systems on the first call. Of course, we're recording this, so it can become part of a series of recordings and events that we'll do, and anybody who's not been able to join us live today will be able to sort of catch up and learn more about the Ghana system. And equally, moving on in a second to our NHS colleagues and Leeds Trinity colleagues that will give you an overview to mental health care, which will be a good basis for going forward, hopefully, on future topics. I mean, I could pause briefly just in case anyone has any immediate questions for Dr. Caroline. Please raise your hand or add to the chat, so we can either take a couple of questions now, or we could come back to all questions at the end of the session. Have we got any hands up yet, Jeanette? Is there a few?
No, everyone's just saying
yeah.
Thank you for the presentation, and it's and yeah, agreeing with what was shared. So yeah, and the points made. So yeah, there's no questions at the moment.
Right. Okay. So please, yeah, we can come back to that at the end. But I think now I'd like to move on to introduce our kind of UK West Yorkshire colleagues as well. So colleagues from Leeds Trinity University and Leeds and York Partnership, and I'll probably just hand straight over to them and let them introduce themselves as well, if that's okay.
Yeah, thanks very much, Tim. So I'll make a start. So it's a real pleasure to be here this afternoon. I'm Anne Kafopoulos. So I'm in the middle there of the slide, and I'm head of the School of Health and Life Sciences here at Leeds Trinity University, and it's a really myself and colleagues have been delighted when Tim and colleagues spoke with us about joining today, and thank you very much, Dr. Caroline, for your presentation. I really enjoyed that, and as I was listening to you, it made there's such similarities and such challenges across the globe that we all face very similar, particularly within mental health and health in general, health services in general, I think. So our presentation title here is From Asylums to Neighbourhoods, as we would like to really talk about mental health services sort of, historically, but also to present day for us in England. So it's about the evolution of community mental health services in England. And I say it's myself presenting, as well as our good colleague Richard Carroll from Head of Operations, who will come on shortly to talk and introduce himself, and also who is at Leeds and Yorkshire Partnership Trust, and Abby Lancaster, who's our Associate Professor and Academic Lead for Nursing at Leeds Trinity University. So this is a real partnership event, as we work really closely, as you do in Ghana, with our mental health services, and it's a partnership, particularly for us at Leeds Trinity University, where we're educators for the future health, mental health nursing workforce, as well as other fields of nursing. So just to give you an outline of our presentation, I am going to give you a brief structure of the NHS in England as is in 2025. And we have got some changes occurring now, particularly within NHS and NHS England. So this is really just to give you an overview, very similar to the presentation we've just seen. So it's really helpful for me to see in terms of Ghana and mental health services. Then my colleague Abby is going to talk a little bit about mental health education and what we do at Leeds Trinity University, as we've been providing mental health nursing for a couple of years now, and the structure of that. And then our colleague Rick will go on to talk about a brief history of mental health in England and really what the future of mental health services is. So particularly looking at maybe some of the challenges and opportunities within England and neighbourhood health, as we speak about today. This is a slide that I thought really depicted. This is from 2023, so it's only a couple of years old. And I wanted to sort of just set out sort of the national down to the service provider level. So we've got the Department of Health and Social Care, a little bit like the Ministry of Health in Ghana, so the Department of Health and Social Care. And then NHS England, and we've got colleagues here from NHS England, and regional teams, so the NHS West Yorkshire regional team. And then we have some of the Care Quality Commission within England. Then we've got a number of integrated care systems across the country, and they are statutory integrated care system bodies with integrated care boards and care partnerships. So looking at how health services are commissioned across the country. And then we've got local primary care networks, local authorities, because we have our own local authorities, local councils that have health and wellbeing boards. So it's this integrated system. And then the service providers that the operation, the primary care, GPs, dentists, pharmacists, NHS trusts, non-NHS providers, local public health services, and social care. So really to that tiered system, but we are undergoing change in England, and we have a relatively new government, and there are changes which are looking at the Department of Health and Social Care and NHS England coming together, and so those changes are currently happening now. And health services are in a state of flux, and there's lots of change, and it's about looking for health, and we have a 10-year health plan for the future. So just to sort of move on to look at the structure of NHS adult mental health services in England, they're provided, in some of these settings. So primary care services such as GPs and NHS talking therapies for anxiety and depression, services for people in acute need such as crisis teams and then A&E psychiatric liaison, and then community services, generic community health teams, specific groups, so around perinatal mental health teams and early intervention and psychosis teams, so very specialist teams. mental health wards and units and longer stay rehabilitation units. And Abby, my colleague, is going to speak next, has got much experience in that, as well as Rick. I'm a registered dietitian by background, but I have worked in within the NHS on an allied health professional, and then very much looking at specialist services such as forensic mental health services. So that's really just a brief overview of the NHS and the structure of our NHS adult mental health services. So I'm going to pass over to my colleague Abby now. Thank you.
Thank you, Anne. Good afternoon and welcome, everybody. My name's Abby Lancaster, and I'm an Associate Professor for Professional Practice and the Academic Lead for Nursing at Leeds Trinity University. I'm just going to share a couple of slides with you this afternoon very briefly. The first slide that you can see at the moment is just an overview of how nurse education in the UK is approved and regulated by the Nursing and Midwifery Council. So in order to become what we call an approved AEI, universities have to demonstrate that we can meet a variety of standards for training and education. And that's institutionally, which are Part 1 standards. Part 2 standards are with our practice partners for the practice element of nurse education, and also that programmes enable students to meet the standards of proficiency for their particular programme of study by the end of their training. And of course, at the heart of all this is the code, the professional standards, which govern our practice as student nurses and registered nurses in the UK. So this is an overview of our pre-registration nursing programme at Leeds Trinity University. So as you can see, our programme is built upon a spiral curriculum where we support and enable our students to integrate and embed, develop, innovate and reflect upon their nurse education. As you can see, nursing programmes in the UK require students to complete 4,600 hours. That's 2,300 hours of theory and 2,300 hours of practice by the end of their 3 years of training. Our programme is designed to support our students to be able to deliver holistic and person-centred care, be culturally competent practitioners, and also to challenge social injustice. Really, we focus on those health inequalities in the UK, which lead to those avoidable health conditions which people within our local communities are experiencing. Key to our delivery of our programme is our Experts by Experience group, who work with our students during, for example, simulated practice education weeks, but are also part of the delivery of our programme and also part of the, as we move forward, part of the assessment of our student nurses. We are really keen, and this is a fantastic opportunity for us to strengthen and support our students' understanding of global mental health. As you've shared with you in the first presentation, to develop a greater understanding of how services are delivered and supported across the globe, and we face some of the shared challenges that were spoken about in the first presentation. Our students go on a variety of different practice learning experiences in order to develop skills within acute, complex and long-term mental health services. Our programme emphasises both acute mental health care, but also neighbourhood, community, digital health, public health and prevention as well, which are really central to the way that our mental health care services are delivered. As you can see on the slide, we have a range of core theory programmes with core themes that are delivered with increasing complexity across the programme. but then also some specialist modules which are delivered in both an integrated way by our adult mental health learning disabilities and child students, but also from a specialist perspective as well. So that's the two slides that I'm sharing with you. Thank you very much.
Good afternoon, everyone. My name is Rick Carroll. I'm Head of Operations at Leeds and York Partnership Trust. So my background, I started in the NHS in 1990. I trained as a mental health nurse, and I began as a student nurse in what was at the time an asylum. And it was a time of great change within mental health. Since that time, I went on to train as a psychotherapist, and then I worked in operations as an operations manager probably for about the last 15 years. So pre-1980, if you go back to the 19th, I won't go too far back, but if you go back to the 19th century, in the UK, there was a move towards the introduction of asylums. We had the Asylum Act. And in mental health, a lot of that was influenced at the time by the Industrial Revolution. And things began to change probably around the 1950s. In 1954, I think it was 1954, 56, we had the introduction of chlorpromazine, which was quite significant. 1954, it's quite a significant change, impact on mental health care. For the first time, we saw people with severe mental illness begin to improve in terms of their presentation and reach a point where actually they might be discharged. Typically, people would enter asylums and remain within asylum for life. It's very rare for people to be discharged and step down. I'm talking about people with the most severe mental illness. And then you also had around 1959 the introduction of the Mental Health Act in the UK, and that was the first time that people were detained into hospital on medical grounds. Prior to that, it was a completely legal process. So you began to start to see a shift in the culture and the attitude towards asylums, and asylums became quite heavily stigmatized. There were cases of people being neglected and people being really vulnerable people being mistreated, and it became seen as a negative. They were often isolated, self-sufficient institutions, and people often became very dependent, and so it's really difficult over time for people to leave those types of environments where the care was quite restrictive. So in the late 1970s, there was a movement developed and called Care in the Community, and that really started to get traction in the 1980s. And you began to see movement towards community services. So you started to see introduction of community mental health teams, day hospitals, and supported living. So accommodation where people would be supported 24 hours a day. But these were residential accommodation rather than hospital placements. And then that became formalised in 1990 when you had the NHS and Community Care Act. And so that placed a mandate on local authorities, councils, to support vulnerable adults in the community. So that was a first. And so you started to see those services develop and accelerate. Then in sort of the around 2000, late 90s, we had the 10-year strategy, the National Service Framework for Mental Health. And that began to set up specialist services. So you started to see the introduction of what we call intensive home treatment teams. So these teams were designed to raise the threshold for admission and also act as a step down from hospital. So it meant that we could treat people who had perhaps more acute mental health problems safely within the community. We also had the introduction of crisis resolution teams. So they were able to support people as they presented in crisis. That helped divert people away from emergency departments to some extent as well. And we also had introduction of early intervention in psychosis. And the challenge around that, I suppose, was that it started, but on the one hand, it was very positive because you had the introduction of more specialised teams. And we also, sorry, I didn't mention assertive outreach, because assertive outreach was very much an American model and also taken up within Australia. Was a useful model for following people up who perhaps didn't want to, who were avoiding services and trying to, who were difficult to engage in services. And often the people that carried the highest risks, both to themselves and to others. But the difficulty was I suppose, as these services have evolved, that the system has become quite fragmented. And what we've seen is that it's difficult for people to navigate the system. Up until recently, we've tended to think in the same way as yourselves. We've thought about primary, secondary, and tertiary care. And in our systems as a provider, primary care would tend to be the focus around, obviously, health promotion and prevention. But in terms of mental illness, tending to focus on more milder conditions, typically anxiety and depression. And then secondary care services, which are the services that I've referred to, which providers such as the trust that I'm employed by would focus on, which would be your specialist community teams and also your inpatient care. So we've got acute inpatient mental health services. They started to see quite fragmented. Patients often complain that it's hard to navigate, it's hard to access services early. And one of the key strategies, if you like, within our long-term plan at the moment is early engagement, because we know that if we engage people earlier and begin treatment earlier, we can shorten the length of that episode of care, and we can hopefully improve the quality of life for that person going forward as well. So taking some of the key principles, for example, within early intervention in psychosis. So we've now got a neighbourhood health strategy, which is all about trying to focus care back into neighbourhoods. So we've almost come full circle from the pre-asylum times. It's a challenge for us because it means beginning to try to deliver services within a community, which historically we've tended to take people away from communities. Once people step out of primary care and into secondary care, and even more so if they go into tertiary care, people have often been treated away from their particular area. And when we talk about neighbourhood health in England, we think of communities up to about 60,000. So a typical sort of mid-large sized town, if you like. So when you look at a city like Leeds, in which I work, you're probably talking about 7 or 8 significant communities within that patch. And what it does really, it focuses on service delivery. What we've tended to do a lot is think about structures and the way that we structure our services. And what we're beginning to do, and the challenge for us now, is starting to think about how we can begin to deliver services together in the community, and where we see some of the best pilot projects. So there's one at the moment I can mention, which is in Cumbria, outside of our area, and we're hoping to replicate that, where they've developed literally a building on a high street, and you've got staff from different specialisms within mental health, all working together. They're working together as a single unified team within that. And they've also brought together local authority, social care. They've brought together primary care. They will have GPs in there. They will have therapists from NHS talking therapies within there. And also community services. So some of the community groups who can provide advice and support around benefits, housing. So all trying to operate out of a hub within the community. And the idea is that people no longer need to be referred into that. People can literally walk in off the street and access that service. It's a challenge for us because in terms of how we begin to refocus our services and deliver into that, like I say, historically, we've tended to think about how we realign. So we are trying to remove some of the fragmentation, and we are beginning to, group services, and often that's around clinical pathways. So, for example, in Leeds, we've recently developed a psychosis pathway where we've brought the key services that would work with people with psychosis into one operational structure. And so more of that. But then the next task, like I say, is bringing it back into the community and how we can integrate the service delivery. And I wanted to mention the Trieste model because a lot of that thinking comes from Trieste in Italy, which is often quoted as a model that we want to replicate. And Italy has quite a different model when it comes to mental health to the UK. So back in the 70s, they completely changed their approach around the Mental Health Act. They literally banned the expansion of inpatient beds. So they forced a situation where communities had to shift to a model where people could remain and be managed within the community. And the service that I mentioned in Cumbria that we're hoping to replicate is predominantly based on the Trieste model. So very similar, where you've got a location within the community that people can access very early before things escalate, but also they would have a small number of beds. There would be residential beds, so you wouldn't be able to detain someone to those beds, but they would be able to provide some overnight accommodation. And that's more aimed at people who are presenting in crisis. And so you've got this shift of traditional healthcare, which is very much hospital-based and reacting and often not intervening until people are much more unwell, presenting with high risk, and shifting more to community-based and being early intervention. One of the cultural challenges that we've got in the UK is that we have had small number but very high profile cases where we've had tragic deaths which have resulted from people who've got mental health problems, who've assaulted people, and it's led to deaths. So it's quite a challenge. On the one hand, we recognise we want to move to a less restrictive model. We want to move to a model where people are able to remain in and return quickly to their communities. But at the same time, we've got a public safety responsibility that we make sure that we manage people well. And there's been almost a refocusing again on the assertive outreach model that I mentioned. So we're trying to manage this tension between being less restrictive, helping people stay at home, but at the same time being able to intervene quite quickly and remove people to a place of safety when they pose a danger to both themselves and to the public. And managing that balance is proving quite difficult and challenging. It's meant that we need to, it's put a lot of focus on the way that we think about risk and manage risk, and having a more dynamic approach to risk management. And I'll finish there if that's okay, Tim.
Yeah, thank you very much, Rick, Abby, and Anne. That was a fantastic kind of overview to our whole system and direction of travel as well, mental health. I've seen a few questions sort of floating around in the chat and ideas for presentations. Would anybody like to highlight any of the questions or put their hand up and ask anything for Rick and the team? I do see one hand is up in the air. So who is that? Who's that then? Anne, thank you. Yes, thanks, Anne.
Yeah, thanks very much, and thank you to all the presenters. Thanks to Rick, because I'd not heard that. So, and it's got me thinking about. I just wondered, in terms of our Ghana colleagues, how that model would be. How does that align or resonate with within Ghana, in terms of that approach that Rick was saying, in terms of wanting to have that community focus, but at the same time ensuring safety and safe place. Does that resonate with our Ghana? I'm just thinking in terms of services within Ghana, and if anybody would like to share that, no worries if not. But I just wondered what perhaps their thoughts were on that, how that model might work. Or maybe something to think about, and vice versa for us.
Yeah, absolutely. Give it another second or two. But so this is the start of developing our community, I guess, around this, and there's definitely opportunity to return to some of these conversations and future topics. So I suppose just so as we're entering that kind of phase of the call and sort of winding down, Jeanette, we've got a poll we were going to activate just to kind of get some kind of immediate feedback on the session. Hopefully everyone's found this a useful experience. But within that poll, there's also the further chance to kind of add any ideas about where we'd like to take this partnership and this virtual collaboration. So I think it's probably the time to activate that poll so everybody gets a chance to start kind of interacting with it. So that's live, and that'll be live for the rest of the call. So please kind of take a look and click through it as you go. But I also see Dr. Anne, you've put your hand up possibly in response to Anne's question there.
Yes, please. So good evening to all of us. And thank you very much to all our presenters. They have done really a great job. I think that, yes, in Ghana, we're also looking at deinstitutionalization and then moving our management of mental health to the community. However, I think that if we want to use this model, which is great, but it has to be graduated because we do not have enough mental health professionals in the community to be able to provide the kind of services where we think that people should be left on their own. Yes, when we look at the quality rights intervention that we are currently practicing, that is what it seeks to do. However, we cannot implement it where, how do you say, wholly without any form of restrictions. Yes, I know that a lot of people will disagree with me, but I think that we are not yet there. However, this is not to say that we lock up wards and squares our clients or our patients, but a little bit of force is still being used. I'm not endorsing that, but for us to be able to implement this fully, there's a lot that needs to be done. There's a lot of investment that needs to be done. So, for instance, if we're looking at holistic care, including housing, employment, and social support, our system is not yet ready for that. However, this is a good platform for us to be able to advocate more for mental health services so that we can get the best of care for everybody that require the services, because it could be any of us at any point in time. And of course, all of us would want to be in an environment where there's no coercion, there's no restriction, and all these services are provided. However, I think that there's a lot more that Ghana needs to do in terms of preparation for a full implementation of this module. Thank you very much.
Thank you, Dr. Amma. I also see Jesselyn. You've got your hand up as well.
Yeah, so I thank you for the presentations. I think you've been really enlightening, I'm in Ghana, and so even it's been eye-opening for me because I'm stationed at a teaching hospital. So although I'm aware of some of the community interventions and some of the things that are being rolled out, I didn't really have a good knowledge of what happens at the very grassroots level. But to answer Dr. Ann's question, I mean, if I understood the question correctly, I think she was also asking about how you guys can also roll out your neighborhood, your Trist-inspired neighborhood mental health program. And I realized that one thing that works for us, like Dr. Amma has said, we still have a lot to do here. But I think at the community level, one thing that really helps is our social systems. So we still have a very we still practice like the extended family system, and then in the very smaller towns and smaller communities, there's still my brother's keeper type of social interactions. And so that helps because as soon as someone realizes that their family member who has a mental illness is escalating, they're able to quickly, call the mental health professionals to engage and then make sure that everybody is safe. So I think that's one way. I'm not sure what your systems look like what's your neighborhood, your social interaction in your neighborhood. But from what we hear, it's usually that, people are not very close and sometimes people don't really interact. But I think it starts from there. So one thing you can do is to really get a lot of volunteers from the community to keep an eye on. So like a peer guided type of thing, so that you train some people in the community so that when the neighborhood team identifies a patient, they have a volunteer who is linked to the patient. And so as soon as there's changes, there's worsening of their symptoms, they can quickly contact the person who can quickly contact the team. And then the community can be kept safe, even though you're doing a home-based treatment. And then I also think that risk assessment is also key, because from the very beginning, if you do your risk assessments, I'm not sure what tools. I know of the hospital-based, like the HCR20 and those other ones. I'm not sure if there are any tools that have been, developed for the community. But I think if such tools are also developed for the communities, I think that it will help people to identify those who can be managed at home and those that you do not have to take the risk to manage at home. Yeah, that's what I wanted to say. Thank you.
Thank you, Jessalyn. Any quick follow-up comments from that? Or I also see Dr. Joseph, you have your hand up as well.
Yes. So, please, can I be heard?
Yes, can hear you.
Yes. Yeah. So, one of the things I also want to add to what has been said is that in our part of the world, we are very religious people, and most of the first point of contact is either a pastor, an imam, or a traditional healer. So one of the things that we are also working on now is to equip these faith-based healers. We are doing training with them to how they can identify some of the signs and symptoms, and we are creating referral channels so that in case they report to them first, some of the cases will be referred to the hospitals and the district hospitals, so that the management will be more collaborative, because the African is a religious person and is a spiritual person, and you cannot necessarily take that out of the context of practicing mental health. So we are also trying to get to a place where we have an integrated care, where there's a smooth transition. When they go to the faith-based healers, they are able to call some of us and create a referral pathway where most of the cases of mental health will not be left at that level, but they will transition to a tertiary facility where they will have the appropriate care. Thank you.
Thank you, Dr. Joseph. And is it Dr. Caroline? You got your hand up again. Or Evans? Can't hear you yet if you're going to come in. In the meantime, thanks again to everybody who's completing the poll and the end. Obviously, we're getting a lot of feedback on the session, which is really great. And I can see people are also making suggestions for what we could return to at a future session, and volunteering to speak and as well and be part of the coordinating teams. That's really, really great. Thank you. Dr. Caroline, are you there? Just so I can see your hand, you're on mute, so.
Yeah, sorry, Tim, not sure if Dr. Caroline is still with us. I think that he kept a note that he had another engagement at 4 p.m. So she
Okay.
left.
Sorry, thank you, Evan. Sorry, because I knew that. Have you got a comment as well?
Right. Just to say thank you. I think that it has been really very informative. Having a clear picture of the different health systems in both Ghana and then also in the UK. I think the comments and the questions that have come now are very well noted. And some of the questions that I read from the chat is in relation to psychotropics and how the systems would be supported by funding so that they will be able to provide the community services more frequently. I think that all these are very well noted, and definitely there will be a response to these questions appropriately from the appropriate quarters. So let's be rest assured, and then keep, sending us most of the challenges that you have. If we have not been able to reach you with that. And as these platforms also, you try to put them there, then we'll be able to really have a deeper understanding of whatever is happening also in the communities. That will help, the future direction of this program and the responses to be provided. Yeah, thank you very much.
Thank you very much, Evans. I think that's a perfect summation of a really successful event. So thanks once again to everybody who's presented and attended. I do really hope this is the start of a a long series of virtual knowledge exchange events, and obviously it's part of a wider managed education partnership too between the NHS and West Yorkshire and Ghana. So we do hope as well to have some news in 2026 about the opportunity for study visits and exchange opportunities in person between our countries too. So, but I think that in the meantime, let's just continue to kind of develop this community, continue with this type of event. I see a comment from Anne in the chat also about involving students in Ghana and getting the student perspective too. We've had welcomed some students here today from Leeds Trinity. So this is a kind of an open community knowledge exchange on mental health between, everybody's welcome basically. So we look forward to kind of fully digesting the comments and the feedback. We'll send a summary of that feedback to everybody who's attended and registered today, and please ensure that's shared more widely as well to encourage further participation. And we do hope to have some news on a date for a further follow-up event in January, February time as well. So thank you so much, everybody, again, and wish you well.